Good evening, everyone. I'm very excited for tonight's topic. Thank you for joining us tonight. My name is Lydia. I am CPD Program Officer here at CESPEN. And before we begin, I'd like to acknowledge that we meet tonight on Aboriginal land, and I would like to pay my respect to elders past, present and emerging. And I also like to offer that respect to Aboriginal and Torres Strait Islander colleagues who might be joining us tonight. And now, without further ado, I would like to invite our GP facilitator for this session, Dr. Janine Hopkins, and I'd like to thank Janine for her extended support in preparation to this session, but also for securing such a special speaker tonight. Thank you, Janine. Over to you.
All right, thanks, Lydia, and thanks everyone for joining us tonight. Our topic tonight is food intolerance, and we're very lucky that Dr. Anne Swain has come along and agreed to speak to us. Dr. Swain is recognised as a leading expert in the field of food intolerance and food allergy, both here in Australia and overseas. She's been the head dietitian of the allergy unit at Royal Prince Alfred Hospital for over 40 years, specialising in adverse food reactions, and she's actually done a PhD on food intolerance. And she's actually been responsible for a lot of the groundbreaking research in determining which foods have what natural chemicals like salicylates, amines and glutamites, as well as quantifying them. And that formed the basis of a lot of tables that are very widely used to help health professionals and our patients know which are low, medium and high sources of these food chemicals. Dr. Swain is the co-author of the book on food intolerances called Friendly Foods and the Royal Prince Alfred Hospital Food Intolerance Handbooks. She's the Deputy Convener of the Adverse Food Reaction Interest Group run by Dietitians Australia and an active member of the Australasian Society of Clinical Immunology and Allergy, as well as the International Network for Diet and Nutrition in Allergy. Dr. Swain has also contributed to the development of policy and protocols for food allergy and food intolerance for New South Wales Health, Food Standards Australia and other professional organisations. She's currently involved not only in the Food Intolerance and Allergy Clinic at RPA, but also in research, educational programs and teaches at the University, Sydney. So with all that wealth of experience, including 40 years at RPA of seeing, managing and researching food intolerances, we were delighted that she's agreed to come and speak to us tonight and share her expertise. So a big welcome, Dr. Anne Swain.
Thank you very much, Janine, and thank you, Lydia, for your introduction. So thank you, first of all, for the invitation to speak tonight about food chemical intolerance. In this talk, I'm going to cover the clinical signs and symptoms of food intolerance and the principles of the diagnostic elimination diet and challenge protocol. Reactions to food can be immunological and non-immunological. The common immunological reactions, as you know, are food allergy and food protein enteropathies like celiac disease. The non-immunological reactions to food involve a range of syndromes and symptoms. It's important to differentiate between these conditions as the symptoms can be similar and can occur in one individual. Food allergy mainly occurs in infants and young children with eczema who are particularly prone to becoming sensitized to foods through the contact with dry or inflamed skin. They often have a family history of asthma, eczema, hay fever, and immediate reproducible reactions after they come in contact with small amounts of the allergens. They also often have airborne allergens, and we detect sensitization by skin prick testing and RAS blood testing. For those that are identified as having a food allergy, the diet is complete avoidance, and they usually grow out of their milk and egg allergies, but it's the nut and seafood allergies that persist through to adulthood. When we're looking at celiac disease due to inflammatory T cells, the age of onset can be at any age. There's usually a family history of autoimmune disease, and they also have chronic reproducible reactions, and the main trigger, of course, is gluten in small amounts. The tests to identify whether they have celiac disease must be done while they're eating gluten, and that is the blood test for the tissue transglutaminase antibodies and a small bowel biopsy. The diet is a strict gluten-free diet, and they usually have lifelong immune reactivity. Food intolerance, on the other hand, can come on at any age. There's usually a family history of hives, headaches, irritable bowel, and mouth ulcers. They have delayed variable reactions that involve the skin, the gut, the central nervous system, and the respiratory tract. And the triggers are the flavours and additives in food, and for some patients, wheat, milk, and soy. These reactions are dose dependent and cumulative, and the only test that's available to work out what people are sensitive to is the diagnostic elimination diet and challenge protocol. Long-term diet management is based on reducing the intake of the various chemicals from the diverse groups of foods that patients react to on challenge. There is a lifelong susceptibility, and there is also variable tolerance. This diagram, developed by Dr. Lobley, an immunologist that I worked with for many years, shows how allergic inflammation and neurogenic inflammation can lead to urticaria, angioedema, and anaphylaxis. Allergies are immune reactions to unique protein components of a specific food. By contrast, intolerances don't involve the immune system at all. They're triggered by various natural food chemicals and or additives, which cause reactions by irritating sensory nerve endings in different parts of the body. Some people are born with a sensitive constitution and react more readily than others to certain food chemicals, smells and fumes, and or medications. And these are collectively referred to as intolerances. Susceptibility to intolerances is probably inherited, but environmental triggers such as a sudden change in diet, a bad food or drug reaction, or a nasty viral infection like gastroenteritis or glandular fever can bring on the symptoms at any age by altering the sensitivity settings of the sensory nerves. Women often become more sensitive in their childbearing years, perhaps due to hormonal changes, which might be nature's way of preventing pregnant and breastfeeding women from eating foods that could harm the developing baby. Mast cells are present under the skin, in the lining of the airways, the gastrointestinal tract, and the central nervous system. In those individuals with allergies, contact with airborne and or food allergens can lead to a release of mediators like histamine, producing a rash or swelling. Antihistamines can reduce the response by about 60%, and steroid can completely dampen the response, but it has undesirable side effects. Physical stimuli like heat, cold, pressure, scratching, and exercise tickle up the nerve endings that talk to the mast cells and then can also exacerbate rashes. The food chemicals can directly irritate sensory nerve endings in the skin and the gut, and these irritated nerves release neuropeptides which act as a direct communication signal to mast cells. Once stimulated, these mast cells undergo degranulation, releasing inflammatory mediators like histamine directly into the tissues, which causes visible flushing, swelling, hives, and or itchy rash in susceptible individuals. In the gastrointestinal tract, sensory nerves can be stimulated by a range of external chemicals that we're exposed to in the diet and in the environment. These may be pleasurable sensations or unpleasant symptoms, depending on the nature of the stimulus, our genetic background, past experiences, and the current sensitivity settings of our nervous system. Individuals who are highly susceptible to this nerve mast cell crosstalk frequently react to the natural food chemicals, additives, wheat, and dairy. So now I would like to concentrate on just food intolerance in the rest of the talk and talk about diagnosis and management. When we're looking at adverse reactions to food in the sense of a food intolerance, it can affect the 4 systems of the body: the skin, the gut, the central nervous system, and the respiratory tract. When it affects the skin, Patients often find that when the chemicals in food tickle up the nerve endings just under the surface of the skin, they'll get itchy rashes and hives and swellings. When it's deeper down, fluid infiltrates and they can end up with swollen eyes, swollen lips, swollen throat. It can look like an allergy, but it's not. When it affects the gut, it's chronic mouth ulcers, nausea, bloating, pain, sometimes diarrhea, sometimes constipation, often called colic or reflux as babies, and irritable bowel as adults. Some of the little girls can get a red fanny or a red bottom, and the little boys can get a red penis, particularly after they're irritated from the salicylate in the diet. When the food intolerance affects the nervous system, it can be headaches, migraine, blurred vision, fuzzy-headed thinking, can't concentrate, feeling tired, lethargic, depressed on one hand, hyper on the other, and then mood swings for no reason at all. Sometimes with muscle aches and pains where the kids will cry out, please rub my legs at night, the growing pains, they often respond well to dietary change. And when it comes to behaviour, we often describe the children as having symptoms of Dr. Jekyll, Mr. Hyde. 1 minute, they're very affectionate. Next minute, get away, leave me alone, and they are very irritable. So the most common symptoms that you see with food intolerance are the recurrent hives and swelling, stomach and bowel irritation, and headaches. Some people can feel vaguely unwell with flu-like aches and pains, or get unusually tired, run down, and moody. Babies can develop colicky, irritable behaviour, reflux, loose stools, sleep disturbance, and rashes. And children can be irritable and restless with the aggravation of behavioural problems such as ADHD. Now, when we're looking at this area, there is a real genetic predisposition. It seems to affect the nervous system, which can then amplify the sensory output. What you find is whether it's a medication, a food, or a smell, a medication like aspirin or Nurofen, in the diet, pineapple, orange, tomato, or in the environment, Dencorub, Dept, petrol, paint, perfume, whether the sensitive individual takes it in by mouth, breathes it in, or rubs it on the skin, it can be absorbed and then they can have their reactions. The external factors, the internal factors, the amplifiers are hormones, inflammation like illness or allergy, and untoward physical and mental stress. And when people are feeling sick or stressed, they often change what they eat and they also take medications, and then the seesaw can start. When we're looking at the types of food compounds that can cause the reaction, we all know about the macro and micronutrients, but it's the non-nutrient chemical components in food, both the naturally occurring substances and the additives, that are generally a problem with food intolerance. A lot of people recognize that if they have lots of additives, they may very well get symptoms. And the particular ones are the preservatives, the colors, and the added flavor enhancer MSG. But they don't often recognize that the natural foods contain also chemicals that are very similar and that can build up and give them symptoms. These compounds are non-nutrient food chemicals like the phytochemicals or the flavor and aroma compounds in food. There are those that are unique to a specific food, like furanol gives strawberries that specific strawberry flavoring. And then there are those that are common to many foods, like salicylates, where larger amounts are ingested overall, and that leads to a dose-dependent and cumulative effect from the chemicals in food. And of course, then they're more likely to provoke adverse reactions. Salicylates are a family of natural chemicals produced by all plants for defense against insects, pests, and microbial attack. High levels are found in fruits and vegetables, herbs and spices, tea, peppermint, licorice, and honey. They're also present in natural flavorings like mint and fruit flavors used in foods, drinks, and liquid medications. and as volatile substances in perfumes, toiletries, cleaning products, washing powders, and botanical oils like lavender, eucalyptus, tea tree, and wintergreen. The salicylate content in food varies according to the variety, the time of the season, the ripeness, the peel being higher than the flesh, whether it's raw or cooked, and flavour really is a good guide to chemical content. The other set of or family of compounds that can be a problem are the biogenic amines that are naturally present in animals and plants, where they act as neurotransmitters, hormones, and inflammatory mediators. Increased levels can develop in foods as a result of protein breakdown due to bacterial action as the foods age or mature. For instance, meats, fish, and cheese, from high temperature cooking like grilling and frying, and with the ripening of fruits like bananas, tomato, avocado, and olives. High levels are also present in sauces, fruit juices, chocolate, jams, to name a few. Glutamate is an amino acid building block of proteins and is found naturally in most foods. Most people think of it as just being added to Asian food, but it does actually occur in most naturally occurring foods. Aged, fermented, or extensively cooked food will have increased levels of free glutamate. In its free form, not linked to protein, it enhances the flavour of food, which is why foods rich in natural glutamate like cheese, tomato, mushrooms, stock cubes, and soy sauce are used to add flavour to meals. For the same reason, pure MSG is added to savoury snack foods, soups, sauces, and Asian cooking. Now, when we're looking at this area, as I said earlier, flavour is really a good guide to chemical content. We all have a preferred taste range of foods that we eat, and for some of the patients, they may be being a bit more adventurous, and that may mean that they have to bring in the range of taste that they can manage. So if we look at salicylates in foods, which is the compound that gives the acidy tart flavour in a lot of fruits and vegetables, and you think about green apples, when they're hanging on the tree and the seed is immature and the tree's stuck in the ground and it can't get away from predators, how does it protect its progeny, the green apples? Well, it makes chemicals and it makes lots of the salicylate. And that's why our parents and the birds and creatures know not to eat green fruit because it'll give a bellyache. When the fruit is ripe and the seed is mature, that's when the plant wants us to eat the fruit and then throw the seed on the ground or poop it out, and that's so the life cycle can continue on. And if we don't do that, it falls on the ground and so it rots and a new life starts. So salicylates, as I said before, is a natural antimicrobial. When we're looking at the amines in food, think about a green banana and that bland taste. Then think about a ripe banana, which is delicious. And then think about a toothpaste and a banana where you chop off the top and squeeze and make it into banana cake. That rich, rotting flavour that you wouldn't eat as a banana, but that you would enjoy as banana cake is a very high source of amines. When we're looking at glutamate, think about white soybeans and white fish, very bland in flavour. And then think about the fermented products of soy sauce and fish sauce. In that fermentation process, the proteins are broken down into the little amino acids and free glutamate is made available. And then they're further fermented and they form those rich, rotting amine flavours. There are a lot of popular diets out there, like the low FODMAP diet, the wheat-free, milk-free, low histamine, sugar-free diets. And when patients or people go on these diets, they take out a lot of food out of or they change a lot of foods in their diet. And inadvertently, they reduce their chemical content of salicylate, amines, glutamate, and additives. And so when you're looking at restricting wheat because of the protein or the gluten or other components in the wheat, you will be taking out or changing foods like bread, cake, pizza, biscuits, which contain a lot of the natural flavors, the additives, and the artificial colors. When we're looking at dairy, and a lot of people try dairy-free diets because they think it might be the protein or the lactose, and those things may be a problem. But inadvertently, when they take out their cheese and ice cream and yogurt, etc., they're also reducing their chemical load. When it comes to sugar, nobody sits down and eats a bowl of sugar and goes, oh, wow, we eat it as cakes, biscuits, lollies, etc. And again, the same principle applies. There are other compounds in those foods that are very likely to be causing reactions. Similarly, with the fermentable sugars known as FODMAPs nowadays, the windy foods, when you take those compounds out of your diet, you take out a lot of other foods that contain those compounds, but they also contain flavors, preservatives, and colors. Now, food intolerance reactions are dose related, and so small dose, no problem. Large dose, and the patients often put the cause and effect together. But it's the build-up effect that tricks them most of the time, where they're okay, then they're not, then they're okay, then they're not. That's usually the reason why they come to see their doctor or their dietitian about reactions to food. And an example of that is the amines in food, where if you have a little bit of cheese and tomato, banana and juice, avocado and mushroom, and then you have the chocolate and you get a headache, most people would blame the naughty but nice last food, which is the chocolate, rather than realizing that it's the buildup of amines from a number of foods in their diet. Similarly with salicylates, lots of fresh fruits and vegetables, and then they have a large serving of berries and they get stomach pain and they get rashes. They'll often blame the berries, not realizing that they can get the same compounds in a lot of other foods. And so the principles of diagnosis that we have put in place, we use the N of 1 trial where every patient is their own control. We eliminate all the possible triggers. We challenge systematically. Then we reintroduce the tolerated substances and finally liberalize the diet to work out the reaction threshold for each trigger substance. And this is what's outlined in this diagram here, where it shows the steps that we work through with patients. If they don't improve on the elimination diet or there's no change in their symptoms, then we know that food probably doesn't have a role in their symptoms, and we show them how to work back onto a normal diet. And this stops people doing the yo-yo. I'm on a diet, I'm off a diet, I'm on a diet again. I like to think of this process as being a journey, and the dietitian is the travel guide. Because patients present with a range of symptoms involving the skin, the gut, the central nervous system, and the respiratory tract. And so the first thing to do is to take a thorough clinical assessment to answer the question, could my patient have food intolerance? Patients often present also knowing that they have many triggers, they've modified their diet, and in our experience, 82% of our patients recognise their food triggers and 31% have modified their diet. They have varying reactivity and they're seeking more information and guidance about where to begin and what foods are safe. Misconceptions are common with the internet and books and magazines. There's also alternative belief systems, and there's a lot of misleading tests out there. There are the unorthodox tests, and then there are also the orthodox tests with mistaken interpretation or inappropriate use. And so I like to direct health professionals and patients to the ASCIA website, where they've got an excellent document for patients, consumers, and carers about these various tests and the pros and cons of them. Now, when patients come to Prince Alfred Hospital with a food intolerance, we have a diet symptom questionnaire, which is actually online and on our website. And later on in the talk, I will give you the link for that, where it asks all the usual questions about the main reason, the symptoms. Do they have anxiety, depression, or an eating disorder? Do they have any other conditions? And then it asks detailed questions about their diet, about smells, about medications, supplements, quality of life, and of course, in children, growth. By the patients filling in this questionnaire, it gives valuable information, and it also gives the patient time to reflect on their answers and saves much consultation time. And it gives time for the dietitian or the doctor to spend time drilling down into the answers to elicit more detail as required. The known triggers and symptoms, we get them to list, and it's a fillable form. We also get them to list how they get on with the low chemical, high FODMAP foods, and we get them to give in detail the sorts of foods they eat, the common vegetables and fruits, and also the beverages that they consume or snack foods. And then that allows us to go through and colour up with green for salicylates, yellow for amines, orange for glutamate, and then the additives in pink, the chemical intake on their diet, and compare it with the foods that they have already recognized to be a problem. Because a lot of patients recognize the foods, but are still having those sorts of chemicals in their diet on a regular basis. We also ask them about their medications because a lot of medications are coloured or the liquid ones are flavoured and preserved. Some patients are taking painkillers or headache painkillers as well, and they'll need to know about suitable alternative. And also dental anaesthesia is often preserved, and they need to know about those products that are not preserved. We also need to ask about any herbal medications that people are taking or any multivitamin supplements, because a lot of them nowadays contain herbal products that are a natural source of salicylate. The next stage of the journey is the elimination diet, the diagnostic elimination diet, which is a short-term test diet that aims to answer the question, does food play a role in causing symptoms? People vary with food intolerance with their reactions to different foods and food chemicals, their degree of sensitivity, their frequency of symptoms, and their personal preferences. And for these reasons, there's no one single diet that suits everyone. It's also important to know that it's not possible to predict from a person's symptoms which food chemicals they might be sensitive to. Although people are usually correct in thinking their symptoms are diet-related, they often incriminate the wrong components. And most people with food intolerance are sensitive to more than one substance. So when we're looking at the elimination diet, there are three areas that we have to concentrate on. The first area I'm going to cover is the food chemicals, both the natural and additives. The next area, when you're looking at a diet, you need to look at gluten, dairy, and soy. And the third area is the windy foods or the low chemical, high FODMAP foods. So when we're looking at choosing an approach, there is the strict, the moderate, and the simple diet. And we outline to the patients what these diets involve, and I'm going to step through them with you so that they can then choose based on their clinical pattern, their preferences, and their lifestyle, what they might like to do. Avoiding the natural chemicals requires an understanding of the food chemical charts. The chemical concentration increases approximately 5 to 10 times as you move across each column, from the low to moderate to high to very high columns. And flavour, as I've said before, is really a good guide to chemical content. Compare the flavour of celery and iceberg lettuce in the low column to olives, seaweed and tomato in the very high column. The problem additives are more straightforward to avoid on the elimination diet, as the food numbers are declared on the packaging by law, and it's a case of avoiding artificial antioxidants, preservatives, colours and flavour enhancers. Food additives other than these ones listed are generally not a problem and do not need to be avoided on the elimination diet. Now, when we're looking at the diets, the strict, the moderate and the simple diet, and what a patient might like to choose that would suit them best, keep in mind that the low or the strict elimination diet is made up of the low foods that are almost never a problem. The moderate and simple approach are made up of the moderate and high foods that may upset people depending on how sensitive they are and how much they eat. The very high foods often cause symptoms in sensitive individuals. So the strict diagnostic elimination diet is made up of just the low foods, and it's for those with distressing symptoms that interfere with day-to-day life. It is the quickest and most accurate way to determine intolerance, and it generally gives a symptom-free baseline on which to challenge. However, it is bland, boring, and antisocial. The moderate approach is for those with less severe or occasional symptoms, or for those individuals that find the strict diet to be too restrictive. And that's when they have foods from the low and the moderate columns. The simple approach is for those with infrequent or mild symptoms. Limiting high chemical foods is often sufficient to prevent symptom recurrences. In other words, they eat mainly from the low, moderates and highs and avoid the very highs, simply pulling back on the frequency of ingestions in that very high column can be enough for some people who present on diets that are rich in these foods. Pulling back on the additives and therefore processed food, as well as chocolate, confectionery, fruit juice, and packaged snacks, can not only result in symptom improvement, but can also improve nutrition. The foods that are most likely to cause reactions are tomatoes, citrus, berries, cherries, fruit juice, dried fruit, and of course foods that contain artificial colours and preservatives. The step-down approach, which is starting on the simple diet, then going to the moderate and then to the strict, takes more time and effort in the long run. It can be a recipe for failure and confusion and may not achieve a symptom-free baseline for challenge in the long run. The next part of the elimination diet is to talk about the gluten and dairy and soy in the diet. And if they've got symptoms, gastrointestinal symptoms as listed here, we often exclude gluten, dairy and soy. If they come in and they say, look, I don't think these things are a problem, we'll leave them in the diet. And if they don't settle down on the elimination diet, then we may take them out at a later stage. Then we talk about the windy foods, the foods that are now labelled FODMAPs. And in clients with gut symptoms, if they experience abdominal pain or diarrhea or excessive wind in response to eating these foods like Brussels sprouts, cabbage, garlic and leeks and shallots, we ask them the question, how do you get on with these foods? And they're usually pretty quick to tell you the answer. Now, these windy foods were cautiously added into the elimination diet in 1988, as it was well known at the time from the NASA astronaut experiments in the 1960s that taken in excess, they can cause wind and loose stools in everyone. People vary with their capacity to absorb fructose in the small bowel, and mannitol, sorbitol, fructans, and galacto-oligosaccharides are poorly absorbed in everyone. Production of gas and other fermentation byproducts that can irritate the bowel normally begins within 30 minutes and reaches a peak within 2 to 4 hours after a meal. The effect should pass off within 1 to 2 days. As I said earlier, clients know when these foods cause symptoms of wind and loose stools and are usually already limiting these foods to within their established threshold. A few simple questions can ascertain the extent to which the FODMAPs impact in their gut symptoms. And so I ask them, how do you get on with these foods? And there's usually 3 answers: okay, don't like it, don't eat it, or terrible gas. And then I drill down and say, well, how much do you eat? How do you eat it? Is it on its own or is it in a mixed dish? Is it raw or cooked? And how long is it cooked for? And how long do you soak your legumes? Because that can make a huge difference to the amount of fermentable sugars in those foods. When it comes to legumes, what I'm asking is, how do you get on with 3 bean mix? Not how you get on with baked beans or a curry or a salad, lentil salad, where it's got lots of other things in the dish. And similarly, a lot of people will say to me, oh, I can't tolerate garlic, but they're talking about having it in Asian dishes or pasta dishes or soups, not whether they can tolerate it in a plain food like garlic bread. When we're looking at the elimination diet, as I said earlier, we look at the natural chemicals, we look at the additives, we also look at gluten, dairy, and soy, and the windy foods and how they tolerate them. And with the patient, we work out what level of diet they would like to do as far as the chemicals, and what level of gluten, dairy, soy restriction they want to or feel they need to do. If they're not having any dairy or soy, then they need a replacement like a calcium fortified rice drink or oat milk, and they need to have extra protein in their diet. And for some patients who are very limited in the foods that they can tolerate, we definitely advise them to get an uncolored, unflavored multivitamin. Now, though there are those in the population who have a cast iron stomach and they can eat anything, anytime, and it never upsets them. Most people live in the middle, where they can tolerate a wide range of foods to a lesser or greater degree. If they have too much and get symptoms, they often will say, the food was great, the company was fantastic, I'll get over this. And they don't come to see the dietitian about food intolerance. The patients that come to see us, I often call them the thoroughbreds, the finely tuned violins, the racehorses. They're often the more creative, artistic, theatrical, reactive individuals, where they only need a little bit of stimuli and they can have a huge response. They tend to react to the additives, then to the flavors in food, and then to wheat, milk, and soy. Think about the sun. There are those of us that go out in the sun and we just go a bit pink. Most of us, we put on sunscreen. But then there are those of us that even if we put on sunscreen, we burn like a crisp. So just like you wouldn't put a fire on the outside, why would you put a fire in the belly if you're a sensitive individual? It's very important that throughout this whole process that patients maintain good nutrition. Good nutrition is about eating from the 5 food groups, not 550 fruits and vegetables. That is variety. So on the diet, we're going to bring in the variety, see if their symptoms settle, test them, and then see how far they can move out at the end. The elimination diet is for at least 2 weeks and up to 6 weeks. And throughout that time, some patients can experience withdrawal symptoms. And the aim is to have 5 well days in a row free of symptoms before they do challenges. We get them to keep a detailed food and symptom diary, recording all the food and drink symptoms, medications, and other diet factors throughout the time. The withdrawal effect can occur, as I said, in the first 2 weeks, where the body's saying, now come on, where's that regular dose I used to get? And it's a little bit like coffee drinking. You know, when you drink too many cups of coffee and you can start to feel a bit headache, a bit shaky, and then you stop it and you can feel a bit headachy. But if you can push through that, afterwards you only need little bits to get the desirable effects without the side effects. And that's the same with the food chemicals in the diet. Can you see also that the threshold is not a straight line? It's a band, because when people are sick, they're at the lower end of their threshold. And when they're well, they're at the top end of their threshold. And this also can be confusing to patients, because sometimes I can eat the food and I'm okay, and other times I can't. The next stage is the challenges, where we're asking the question, which foods or chemicals trigger symptoms? We have done capsule challenges, and we've also done food challenges with patients, where the capsule challenge is taken on a 1 day and the food challenges are taken over a series of days. And what you find, there is 3 types of reactions. There's the acute or quick reaction that comes on 1 to 2 hours later and lasts 1 to 2 hours. There's the intermediate reactions, which usually come on 4 to 8 hours later and last a day or 2. And then there's the nasty ones, not in severity, but they take 2 to 3 days to reach a peak and anything up to 1 to 2 weeks to settle down. These reactions often patients don't pick up, and so they keep on eating the food that's setting off their reaction and hence prompting a referral. With the food challenges, we give them detailed instructions how to do the food challenges, that they must have 5 well days, and then that when they start doing the food challenge, if they get symptoms, they should stop the challenge, let the symptoms settle, have 3 well days, and then they can move on to the next challenge. Should they find that that challenge they don't react to, they still need to go back onto their strict diet for 3 well days and then move on to the next challenge. This last challenge of glutamate illustrates an additive challenge where they only need 3 days in order to identify whether these things are a problem. But they must make sure that they have 3 well days before they move on to the next challenge, because some patients can have a delayed response, as I said before, where their response builds over a number of days. The pitfalls with the food challenges are when the baseline diet is incomplete and the signal to noise ratio is high. And also when adherence is not good, they need to have 5 well days in a row before you challenge. We challenge with a group of chemicals of food, not with single foods, and we don't choose foods like tomatoes, mushrooms, or wine that contain a number of chemicals. You also need to make sure that patients have an adequate dose and a duration with their challenges. And they need to allow for the 3 well days in a row before they rush on to the next challenge. Confounding factors like infection, hormonal changes, and stress also need to be taken into account. Now, when we're looking at the challenge methods, people would see the double-blind, placebo-controlled capsule challenges as the gold standard, compared to the food challenges, which are open challenges. So what should be the gold standard? We compared the responses of 51 patients who did both capsule and food challenges for salicylates, and we found good sensitivity and specificity for the challenge. We similarly looked at amines, and we found, again, good sensitivity, specificity to the challenge. Another question that people ask is, what compounds cause what reactions? And it's not the compound that causes the reactions. We need to take into account the target organ susceptibility. So if patients present with urticaria, they tend to get urticaria in response to a salicylate challenge. If they present with irritable bowel, they tend to respond with gut symptoms in response to the challenge. And headache, they respond mainly with headache to the challenge. If they present with a range of gut and central nervous system symptoms, they will respond to the challenge with that range of symptoms as well. And this pattern is seen with the amines in food and also with the additives like the glutamate in food. So the reactions depend on the individual, not necessarily on the compound. The other thing to keep in mind is that these reactions are very idiosyncratic. And I've got a group of migraine patients here where you can see their reactions to colours, salicylates, preservatives, and amines. And there really is no pattern. Each person reacts in their individual way. Once they've finished their challenges, we then go on to prescribe a personal diet that's individually tailored to their challenge responses. And it involves adding back the foods that contain the natural food chemicals that the client did not react to on challenges. The personal diet should be tailored to the individual's challenge reactions, and we encourage them to follow this strictly for 3 to 4 weeks and then start liberalisation in a gradual and systematic way. In this way, we've got a double check for the challenge responses. Throughout this time, good nutrition needs to be maintained on all of the stages of the diet. And we give them a personal diet based on their challenges. And here I have an example of a low amine or a low glutamate diet. After 3 to 4 weeks on their personal diet, clients are encouraged to gradually liberalise their diet to find their threshold for each compound they've reacted to on challenge. This is the maximum tolerated amount of a particular food chemical before symptoms recur or worsen. These food chemical charts are very useful for clients to liberalise their personal diets by adding in foods from the moderate to high chemical type columns and seeing how far they can go. The reason these were put together because in times gone past, patients tried to use capsicum and green apples and pineapple, and very quickly they got symptoms. And that's why we decided to give them these charts of low, moderate, high, and very high, because low foods are almost never a problem. Moderate and high foods may upset depending on how sensitive they are, and very high foods can often cause a problem. And when we asked them why they added back capsicum, Granny Smith apples, and pineapple, they all said the same thing. They were wanting more flavour. And so what we encourage them to do is to introduce gradually across the charts to see how much they can tolerate. When we developed these charts, we developed them based on the literature. We also took into account the type of food, the serving size, the preparation and the processing, storage, availability, and the dietary patterns and the changes that have occurred over time. For example, the Australian diet was originally a traditional English, Irish, Scottish diet, and now it's been broadened to incorporate a wide range of diets from various ethnicities, including the Mediterranean, the Middle Eastern, and the Asian diet. And these food chemical charts have become the centerpiece of the dietary investigation and management protocol. Liberalising is about a trial and error process, and it's best done in a slow and systematic way. And in our booklets for each food chemical, we get patients to begin with choosing a starting amount, gradually stepping up their intake and monitoring their symptoms. If they get symptoms and they're unsure whether they are tolerating this food, we get them to continue on the same level and see if their symptoms settle. If their symptoms recur or worsen, then they can pull back a little and wait until the symptoms settle and then try stepping up again until they reach their maximum tolerated threshold. Lastly, we're going to cover living with intolerance, and this is about adjusting the diet to balance the food choices and their lifestyle. Long-term dietary management of food intolerance is a balancing act, and once patients have established their thresholds, they're able to adjust their diet and lifestyle and make a personal choice about how to balance the benefits of being free from distressing symptoms against the inconvenience of restricting their dietary choices. Common scenarios are seen in the long-term management, and these include a temporary lowering of the threshold with illness like a heavy cold, flu, or gastroenteritis. And if this occurs, patients need to cut back for a while, allow symptoms to settle, and then increase again as tolerated. Most patients with food intolerance push the boundaries of their tolerance now and then, and some find their reaction threshold increases over time. However, if they experience a recurrence of symptoms over a period of time, they're advised to pull back until they've recovered, and then liberalise gradually again until they reach their threshold. Patients binging on high and very high chemical foods when adjusting the diet are likely to experience the yo-yo effect of recurrences of their symptoms. Long term, you want to put the patient back into control, where the patient does not have to focus on being on a restricted diet, but rather they can choose when, what, and how much of their trigger foods they consume. So in summary, investigation involving clinical assessment, diagnostic elimination diet and challenges, and management leading to a personal diet, liberalising and living with food intolerance is a journey, and the dietitian is the travel guide. The resources for this are available on our website, and if you have any questions, please do not hesitate to contact us at this email address at the RPA Allergy and Intolerance Dietitian Clinic, because we're happy to assist. I would like to acknowledge Dr. Robert Lobley and Dr. Valencia Suter and all the dietitians at the RPA Allergy Unit for their work in developing the diagnostic elimination diet resources. And for further assistance, here is the email to contact us. And so now I will pass over and finish these slides for any questions.
Thank you, Dr. Swain. That was a very comprehensive and interesting talk. I've got two questions here, and then also if you have a case study, you might want to, I think you mentioned that you might want to do that. But, and also I've got, here we are, one, I think you talked about the different things that make your threshold change. Someone's written, if a child has a gastro allergy with dairy as a baby, I don't know if that means they had gastro. Now, at 7 years, it is an intolerance. Are there ways to manage them? Example, dairy ladder or lactase, or a good option, or is it long-term better just avoiding it?
When you're looking at a milk allergy, and that is an immune reaction, they are best to work through a milk ladder to encourage them to introduce small amounts of dairy, first in tiny amounts and in cooked form, and then gradually increasing as they desensitize. When you're looking at a lactose intolerance, you can use lactase, or you can use lactose-free products. And when you're looking at a milk intolerance, that's when it is dose related, and again you can increase over time. So milk is one of those foods that you can have a milk allergy, you can have a lactose intolerance, and you can have a milk intolerance, and each one needs to be identified and managed separately.
Could they change something like a sort of a lactose-free milk and sort of as their source and just see if that makes a difference? Or,
Yes.
And is it sometimes the cow's milk protein that people are sensitive to, or the lactose in it? With milk tolerance?
Yes. When you're with milk intolerance, there can be lots of things in milk that they can be intolerant to. As I put on the slide, you've got the protein, you've got the lactose, but you've also got the flavor that's coming through from what the cow eats. And you've also got chemicals that are used throughout the processing, or it could be that they're having it in a complex food like cheese or a flavored milk, where there are other chemicals being introduced into the product.
And is mast cell activation syndrome, is it similar to food intolerance?
Mast cell activation syndrome is something that's a label that's come out more recently. And in our experience, there are some of those patients with mast cell activation syndrome who definitely have food intolerance and benefit from doing the elimination diet and challenge protocol.
And are the elimination diet handbooks available to GPs or the public?
They definitely are. And if you go onto our website, they are available for purchase.
And I think that's if you go onto the RPA allergy immunology sort of site, and I think there's a section, isn't it, patient resources or patient help?
There
Click on
is.
and scroll down.
Patient resources is where you'll find it.
Yeah, and scroll down and you'll find food intolerance, and you can click on that and get some information in the sheets that Dr. Swain was mentioning about, food and diet symptom questionnaire. And also there's other ones I think that you can click on, that they can email you and you can send them other sort of information as well.
Yes.
Yeah. Someone said, can you be intolerant to makeup as a patient identified as feeling unwell when applying makeup?
Some patients do find makeup can be a problem, and we would suggest that they go and see a dermatologist first of all. But the smells in makeup and also some of the excipients in makeup can also irritate them. So in patients with food intolerance, we advise them to use lightly scented cosmetics and toiletries. A lot of those patients have already identified which products suit them and which don't. And so if they've already done that, we allow them to continue on with those products.
And also, and you mentioned there was a genetic component. So in families, because often I find that if you talk to the parents, they sort of, with a child with, say, food intolerances, they'll sort of say, oh, no, I don't have any problem with that. And if you actually say, well, could you eat chocolate? Oh, no, I get a headache with that. Or could you eat that? Because I think adults, we tend to self-select what we tolerate, sort of thing, if people are prone. But do they tend to have the same thing if you have GIT symptoms in a child? Does the family have GIT symptoms? Or if they get migraines in a child, does the parents often have migraines? Or are they different, the 4 different systems that you mentioned?
When you're faced with a patient and you wanted to ask about family history, I find there are 2 questions that are really helpful to ask. The first question is, who in the family has asthma, eczema, hay fever? And I always say to them, who has asthma, eczema, hay fever? Mother, father, grandparents. And then I draw the family history diagram, mother, father, grandparents. And if you ask that question, they will reflect and be able to tell you. And that's the allergy tendency. And then when it comes to intolerance, I ask them the question, who in the family has hives, headaches, irritable bowel, mouth ulcers, or fussy eating. And again, if you give them a moment or two to reflect, they will go, oh, yes, well, my mother, she's got an irritable bowel, or she's fussy about food. And you can see that there is a genetic predisposition to this. When it comes to the symptoms, yes, patients with irritable bowel often have parents, one or other parent or grandparent, who have gastrointestinal symptoms. And similarly with behavioural responses or headache or skin responses, that often runs in a family. But not always are the symptoms of the child the same as the parents. So the parent may have an irritable bowel with pain and bloating. The child may have more diarrhea, depending on what foods they're consuming and what chemicals set them off. But there is most definitely a genetic predisposition to this.
Is it mostly, you were saying about English and Scottish and Irish diets that we started and we've liberalised it with multicultural sort of foods. Is it mostly that group that is more prone? Is that why English chefs are boring?
I like what you're asking. Yes, they were, they can be prone, but I've also seen patients from other cultures, Indian, Asian, Mediterranean, and Middle Eastern, who also have food intolerance. So it's something that affects across the cultures. And when you ask them, they often come in and they'll say, oh, yes, I'm seen as being fussy, but I know that too much curry or too much very flavoursome food will upset me. So food intolerance is across all cultures, but you'll find that there are those that have got the cast iron constitution, those that can get away with a certain amount, and then those that find even small amounts can upset them. And like I said, most people will say, oh, the food was great, the company was fantastic, I'll get over this. And they'll often say to you, oh, I know, I eat everything. But when you drill down and ask them, well, do you eat some of the really highly flavored foods? They go, oh, a bit, but not a lot. So you need to drill down a little bit more to actually elicit that information.
And also, is there any gender or age group that's sort of the highest?
Yes, what we find is that we see equal numbers of boys and girls, but we see 3 women for every 1 male. And that may have to do with females being more sensitive in the childbearing years.
And does it change over time if you have a colicky baby or a kid that's behavioural issues that might be related to food, as they get older as adolescents or adults, do the manifestations change or do they just lose that feature?
Their symptoms can change over time. In other words, they may start off as the irritable, colicky, refluxy baby, who then grows into the fussy eater and gets a few gut symptoms, who then grows into the young adult or older adult who has an irritable bowel, who then may also develop headache. So yes, your symptoms can change over time. Your symptoms can also wax and wane over time, depending on your sensitivity, but also the foods that you're eating. It's not uncommon to see people when they leave home, like going to university or to work, and they start to socialize more with their peers and eat out more, and then they start to get symptoms. Whereas before that, they were eating food from home, which often was less flavoursome or had less additives in it.
And can you, inverted commas, grow out of food intolerances? Or do you think, as you're saying, it just changes?
It can change over time, but when you say, can we grow out of it, our tolerance can change over time. And for some people, they can improve over time so that they can eat quite widely within the range of foods that they enjoy without getting symptoms.
Now, someone's asked, is it worthwhile to advise the patient to eat the food they are intolerant up to their limit in order to train them, to make them become more tolerant to the food?
Again, everybody has their level of tolerance. Pushing them to have more food won't increase once they're at the top of their tolerance. Pushing them to have more food won't increase their tolerance. It'll just give them symptoms. So there is a range to everybody's tolerance, as I showed on that slide with coffee drinking. And having more of the food will not necessarily raise their tolerance. It'll just give them more symptoms.
Mm. And do patients with food intolerance have a problem with vaccines? Are there any they should avoid?
No, but we have seen some patients after they've had COVID vaccine, sometimes they have had side effects, particularly in the ones that are already food intolerant. And what they found was they found a decrease in their tolerance, which improved over time.
And if we've got, you mentioned about breastfeeding our mothers and some coming through the milk. If you have a baby that has a very difficult to treat nappy rash, which you sometimes find, or you mentioned vulvitis in children, um, what would you tell the mother? Would you change the mother's diet if it's totally breastfed? Would you just reduce salicylates? Because it's hard to put them on an elimination diet sort of thing. Are there common things you might just try in that situation to avoid?
Absolutely. If I saw a mother who was coming in with their baby to see the pediatrician, and this was one of the symptoms, and they were breastfeeding, we would encourage them to continue breastfeeding. We would also then talk to them about the principles of food intolerance, just as I've outlined to the group tonight, and would discuss with them the main triggers for nappy rash. And in our experience, the main trigger is the salicylates in food. So you wouldn't restrict it completely, but you would suggest to the mother that maybe she'd like to cut back on the salicylates in food and try a more simple approach and see if that helped with the baby's nappy rash.
So a lot of the fruits, sort of, except for certain pears and that, you cut it down.
In
And
other words, bland fruits like pears, apples, bananas, but not the berries and the cherries and the citrus fruit. They're the ones that are much higher in salicylates, and they're the ones that are more likely to upset a sensitive baby.
and it's often in summer you often find the mouth ulcers people present with that often you lose when the fruits go out of season. And I guess that applies. Does that apply the salicylates to the babies who are very colicky and refluxy sort of, and you can't find any other organic cause obviously because usually it's just that.
And then for the mothers, they may just decide, well, why don't I eat a slightly blander diet and cut back on some of the very high chemical foods, be they salicylates, amines, or glutamate, and see if it makes an effect. Try it for a couple of weeks, and if it makes effect, then that's great. And then they can start to liberalize and see how far they can go.
I think that's where the tables that you mentioned come in very handy to be able to show
Yes.
patients. Yeah. And you mentioned that, as foods get riper, they get more amines and less salicylates. But you also mentioned about food, whether it's cooked or raw. I just wondered if you could elaborate on that. How does it affect our management? Do some things have raw or cooked foods have higher certain food chemicals?
When you've got raw foods, and particularly fruits and vegetables, or particularly fruits, you've got first of all the skin, which is a much higher source of the natural chemicals and particularly natural salicylates than the rest of the fruit. But secondly, when you cook a fruit, you usually steam it or boil it in water. And there's lots of liquid that comes off. And if you discard that liquid, you discard a lot of the salicylates that's present in the fruit. And so that's why cooked fruit is less than raw fruit.
And does that apply to vegetables as well? Because we mostly, cook our vegetables.
Yes, and the same with vegetables. So the cooking doesn't decrease the amount of the chemicals in the food or the salicylate, particularly in the food, But what happens is that the salicylate comes out in the water, and if you discard the water, then the food is a less source of salicylates. Of course, if you eat the food or the fruit with the juice from the fruit that has been part of the cooking process, then it doesn't change the amount of salicylate in the food.
So if we're buying tinned pears, which have the lowest salicylate, we have to get them in syrup, not juice.
Particularly because if you look at the label on pears in juice and fruit in juice, they often use a range of fruit juice, and it's whatever fruit is available at the time that they would use. So there's no guarantee that when you get pears in juice that it's going to be in pear juice. It may very well be in some other fruit juice as well.
So it sounds like we need to tell people who are sensitive to salicylates to peel their vegetables and fruit very thickly if it's a natural pesticide under the skin.
Correct. Because then they're going to reduce their intake of those foods considerably.
Right. Patients often ask, are organic foods better?
Organic foods rely on the natural salicylate content as an antimicrobial to stop bugs eating them when they're growing. And so organic fruits and vegetables are actually higher often in flavour, but they're also higher in salicylates.
So avoid organic ones and peel them very thickly and cook them, basically, if someone's sensitive.
Yes.
Yeah. Now, you've mentioned about the questionnaires and that we can use to sort of see if people are reacting to certain things, or often they have an idea and they'll say the kid goes feral if they have this, which may still be a threshold thing. What dietitians can we then refer to, and how can we find them that have knowledge about food intolerance? Because not everyone has knowledge about it. So we can refer to and they can do sort of any challenges or look at their diet appropriately.
The best way to do that is to either inquire of the dietitians around your area that you often refer to, but I would also advise people to go to the Dietitians Australia website and look up those dietitians who work in the space of adverse food reactions. It's a searchable site, and so you'll be able to look up the dietitians in your area that can assist in this area.
And you run a clinic there. Can we refer to that clinic? Where do we refer and how do we do it? And what is your waiting time for the food intolerance clinic? You'll probably be inundated now.
The referral system is outlined on the website for the Allergy and Intolerance Dietitians Clinic. And if you refer to that, it gives you the criteria for referral and the types of patients that we see.
And is there a long waiting time at the moment?
At the moment, the waiting time is reasonable, within a month or two.
There was a lot of talk with preservatives, not just the natural things as you mentioned, but preservatives and bread. And I think Baker's Delight has their franchise from their popularity based on, no 282 sort of thing, no propionates in bread. Could you just tell us about that? Is that true that became, people twigged when they were in Darwin, a paediatrician or something, realised the kids were getting very feral there, and then they realised they're putting more bread preservative. Is that correct? And what do we need to avoid in kids who are sensitive to it?
In Darwin, yes, they noticed that they were using lots of propionate in bread, and that was quite some years ago.
Or
And
in summer.
yes, and in summer, and the individuals involved contacted us at the allergy unit, Prince Alfred Hospital, and asked us whether we had noticed this. We'd been challenging with propionate for quite some years and advising patients that if they were sensitive to propionate, to avoid the preservative. With the work and the publication of an article about propionate in Australian breads and the effect that it can have on individuals, Baker's Delight then took propionate out of their breads, and so did most of the bread manufacturers, the large bread manufacturers. And they then used other compounds or vinegar in order that as a mold inhibitor. More recently, you'll see that some of the breads nowadays have fermented wheat added to the bread dough, and the fermented wheat actually develops propionate naturally as part of the fermentation process. And so there are small amounts of propionate in breads that have fermented wheat in them. But generally in Australia, most breads do not use added propionate in the quantities that they used to use, or even use them at all. They tend to use vinegar, or they use a bit of fermented wheat.
And for that, I think that was a behavioural effect, wasn't it, in children that they noticed in
Yes,
in Darwin, because some of the canteens, I think, also sort of stopped using 2-8
they did.
potatoes and
They
2-8.
did. But propionate, in our experience with double-blind placebo-controlled challenges, you can have skin rashes, you can have gut symptoms, you can have behavioural problems or headache in response to these compounds. Janine, I was wondering if if you mentioned doing a case history, and I thought I might finish, if that's okay with you, with a case history of someone who came to us with food intolerance and what the outcome was like, and then how they developed an allergy later in life. And I thought you might be interested in that.
Excellent, yeah.
All right, so what I will do now is I will share my screen again. And let's talk about dietary investigations and the case. So as we discussed, patients present with a range of symptoms, and so a thorough assessment has to be done. Could they have intolerance? And we get them to fill out a questionnaire. Now, the case that I've prepared is one of a 40-year-old female presenting with anaphylactoid reactions, skin reactions, gut, respiratory, and neurological symptoms that she'd had from childhood. She had a family history where her father was a plain eater, had asthma and emphysema from his smoking, and a mother who had irritable bowel and reflux. I went through and took a diet. She filled in a diet history, and I went through and coloured it up for the salicylates, the amines, the glutamates, and we found, and you could see that overall she had a very colourful diet. When we talked about the known triggers that she'd noticed, apples gave her nausea, banana gave her angioedema, peaches, oranges, and berries gave her symptoms. So did spinach, mushrooms, mature cheese, and she'd recognised when she went out to dinner that garlic, prawns, spinach and ricotta and vegetable soups upset her. She also had recognised that aspirin gave her a range of symptoms. I then asked her the question about the windy foods and how do you get on with those? And again, she said, generally okay. Now, in her diet, she loved tasty foods like Turkish, Moroccan, Middle Eastern, and Lebanese and Italian food. And she had been investigated previously for food intolerances before she came to see me. She had reactions on challenge to salicylates, amines, glutamate, and tartrazine, but she'd continued to have problems. And we wondered about this yo-yoing effect. I'm on the diet, I'm off the diet, I'm on the diet, I'm off the diet. And so we discussed the elimination diet, doing it again strictly, looking at the food chemicals, looking at the gluten and dairy, and looking at the windy foods all in one thing, and doing that for at least 2 weeks to see whether her symptoms settle down. On the strict elimination diet for 6 weeks, she had 90 to 95% improvement in symptoms. for the skin, for her anaphylactoid reactions, for her mouth ulcers, nausea and pain, for her fatigue, and for her joint aches and pains. So then we moved on to do the challenges. And what we found was that on challenge, with the double-blind placebo-controlled challenges, she had angioedema and asthma to salicylates. Amines gave her a rash, laryngeal edema, gut and joint pains. Glutamate gave her a headache, nausea and angioedema. Propionate, the bread preservative that we were just talking about, gave vertigo, laryngeal edema, and a fall in blood pressure. Antioxidants gave nausea, headache. She felt spaced out and joint pains, and colours gave her urticaria, angioedema, and asthma. When it came to the personal diet, we liberalised the diet to see how far she could go, and then we talked about how far she could liberalise the diet in order to be able to tolerate her maximum threshold. And we gave her an example of what to do. And the example that works best for most patients is having 3 days introducing the foods and then a couple of days off, and then 3 days again, but making sure you use different foods, in this particular case, different foods that contain salicylates or amines, not using the same food like carrot, 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 day after day. We also get people to increase the amount slowly over time. And what we found with this lady was that and we talked about the common scenarios, she was able to work through those. And we stopped this yo-yo that was going on, and she was able to liberalize her diet and see how far she could go. Long term, she felt well with no rashes, increased energy, decreased pain. And after she started to liberalize her diet, she found that she could tolerate 1 to 2 serves of salicylate and 1 to 2 serves of amines per day before experiencing her red face and her choking laryngeal edema. And so this comprehensive approach covered the chemical composition, the amount, the frequency, the form, the combinations, and the shopping and preparation. She went on holidays to Queenstown. And 7 years ago, our patient went on holidays and had a full-blown anaphylaxis after eating a burger for lunch at Ferg Burger, followed by fish and chips and wine for dinner. And she then had 5 recurrences over the next 2 days. 5 days later, she had an anaphylaxis after having veal at an Italian restaurant, and she required adrenaline before boarding a flight home. These recurrences occurred over the next 5 days back in Australia. On the advice of her doctor, she had a blood test for alpha-gal, as she recalled having an infected tick bite some years previously. And Cheryl Van Noonen is the main doctor in Australia who's been looking into this area of tick reactions and alpha-gal, and they're particularly prevalent in the eastern seaboard of Australia. They found her on alpha-gal testing in February to be 15.6. And she went on a diet free of mammalian meats, avoiding all red meats like beef, lamb, pork, goat. She also avoided any products that had artificial blood in them or all forms of gelatin. And she had no further episodes. Serial measurements diminished of her alpha-gal over time, and now she's ready for a challenge, but then she had COVID. This case shows how one individual can have a food allergy and a food intolerance due to the different mechanisms. And so your question earlier about can you have allergy, can you have intolerance, and can you also have a lactose intolerance, can occur in individuals, in one individual. So I thought I would just show you this case to highlight that.
Yeah, it's very difficult having meat allergy, isn't it, in our society, because it's everywhere. Yeah.
It definitely is. And it's something that's been increasing over, or we've become increasingly aware of. The patients that we've seen at Prince Alfred Hospital, they're often keen gardeners, and they come from usually the North Shore or from the South Coast, where they've been getting out in the garden and they've had tick bites, and they have just brushed them off and gone, oh, well, that's okay. And then later on started to develop their red meat allergies because they haven't realised that they've been sensitised to the protein.
A lot of kids in Australia go on school camps, don't they? So they often get tick bites sort of at that age as well, sort of early on. Yeah.
And so we advise them to be very careful and try to avoid any further tick bites. And if they can do that, a lot of them grow out of their red meat allergy over time.
And I think the advice now is not to try and remove the tick, but to try and freeze it, like get one of those wart sort of kill things from the chemist that freezes. So rather
Yes,
than try and pull it out in case you get more envenomation.
absolutely.
That's very sobering, isn't it? That's been a very comprehensive talk. Thank you very much, Dr. Swain. And resources, I think you've mentioned some resources there and on your website. We'll send those to everybody attending.
Mm-hmm.
Also, there's the Food Intolerance Network run by a scientist, Sue Dengate, and her husband. Their website, fedup.com, they often sort of use a lot of and give a lot of credit to the Prince Alfred work that you've done. That's also a resource for people who might want to look up something particularly unusual. Though I guess the other thing is that you have lists of things such as, toothpastes or other things which are sources of salicylates that are actually very useful. People who have sticking to a diet and then find there's breakthroughs in their children. So there's a lot of resources on the Prince Alfred site, which is very, very helpful. But we'll send you links to those for everyone attending. But thank you for a very, very comprehensive, very, very big topic and very interesting sort of talk. That's been excellent.
Thank you for inviting me to speak.